Good morning, everyone. I'm so excited to be here and kick this very important, very exciting session. I'm going to be talking about the most exciting topic, in my humble opinion, which is the important role of MRI and specifically quantification analyses in MRI in clinical practice in this new era of disease-modifying therapies for the treatment of Alzheimer's disease. These are my disclosures. And, as a background, I'd like to bring up some numbers. So just, for your information, there's about 460 million people currently living on the Alzheimer's disease continuum. In fact, it affects about 40% of the global population 60 years and up. Meanwhile, the healthcare costs are astronomical, and they're projected to surpass $3 million by 2060. So this really highlights a really urgent need to develop both methods of early detection and also appropriate therapeutics. So recently in the US, we've had approval of 2 anti-amyloid monoclonal antibodies for the treatment of Alzheimer's disease, Leqembi or lecanemab and Kisunla or donanemab. They are both disease-modifying therapies, and what they actually do is reduce the progression of cognitive decline compared to placebo. So this time, actually, they do not stop or reverse the progression, but they just slow it down, and it's about 30% for both of these drugs. However, they also have really striking side effects known as amyloid-related imaging abnormalities, or aria. And as these drugs are shifting from the research setting into clinical practice around the world, it's becoming a reality for all radiologists and neuroradiologists. And the incidence of aria, depending on the therapeutic, ranges somewhere between 20 and 30%, so not insignificant at all. So, as we know, care is not standardized, and when you think about the AD disease continuum, there's about 3 years before the onset of symptoms and diagnosis. In fact, about a third of patients with early and mild signs and symptoms go unrecognized, especially in the primary care setting. And when you look at the data from the IDEA study in the US, for example, there was a change in diagnosis following an amyloid PET scan in about a third of all subjects, going from AD to a non-AD dementia and vice versa. So that really highlights a need for, again, accurate diagnostics and accurate imaging tools. And in fact, about 80% of people are diagnosed with a delay. About a quarter of patients are started on suboptimal patients. And once we hit treatment monitoring landmarks and assessing for ARIA, up to 80% of these safety events may be missed. So MRI and structural imaging, in addition to molecular imaging, really plays a central role in Alzheimer's disease, both in a diagnosis and also in monitoring treatment response. So each patient on these disease-modifying therapies targeting beta amyloid will have at least 4, and likely more, MRI scans in the first year of treatment. They'll have a baseline MRI within the first 3 to 6 months, and then they will have regular scheduled safety monitoring MRIs in addition to additional MRIs if they present with symptoms. This, of course, as you can imagine, really burdens radiology practices. My colleagues at Washington University, for the first 100 patients they had on these therapies, they scanned over 1,000 additional MRI scans. Some projections are that there will be over 17 million additional MRI scans across the US, and over 40% additional scanning and reading capacities. So this really highlights a potential for AI tools and a need for MRI quantification. So icometrix has developed FDA-cleared tools for both initial diagnosis, or the start of treatment, and then for the follow-up of ARIA. They have AI-assisted tools for the start of treatment, where they offer cortical volumetrics to supplement differential diagnosis considerations. They give percentiles of MRI volumes compared to age and sex match controls. They provide automated mesial temporal atrophy scores to accurately support an early and timely diagnosis of AD. And if you just think to yourself about, say, an 85-year-old patient and think of like a coronal view through the mesial temporal regions, you will agree with me that it's sometimes really difficult to determine if that mesial temporal atrophy is normal or advanced for age. So statistics say that in normal aging, people 60 years old and up, the loss of hippocampal volumes is about 1.4% per year, and then in Alzheimer's disease, it approaches 5% per year. So it's sometimes really difficult to see it purely based on treatment assessment. And then, of course, it allows us to assess white matter load and supplements the Fazeca scores that are used in clinical practice. In terms of AI assistance for treatment monitoring, they have tools assessing both the flare sequences for ARIA-E, which compensates both edema and effusions, and ARIA-H, which really stands for microhemorrhage and superficial siderosis, which are detected by the GRE sequence. So you can see here kind of the progression of a certain patient where we have the initial diagnosis, volumetric MRI, followed by an initiation or eligibility MRI prior to treatment start. And then during the course of the disease, these tools can be used to both detect ARIA and then document resolution of ARIA-E or stabilization of ARIA-H, at which point in many cases, the patient can go on to successfully continue treatment with an anti-amyloid therapeutic. So in conclusion, we are developing a quantitative brain MRI and quantification analyses now as standard of care in clinical practice. They are typically workflow integrated with PACS systems to ensure workflow organization. They have been validated by multiple reader studies, which are published in the literature. They are also cleared by various regulatory agencies, including the first FDA clearance for an ARIA assessment tools. And more recently in the US, we are very fortunate to have a Category 3 code for appropriate reimbursement of these studies as well. So with that, this is very short and very sweet, but I thank you for your attention, and I'd be happy to take any questions either now or at the end of the session.
Thank you, Anna. We do invite the audience to come and participate and ask any questions, but in the absence of any intriguing questions, I wanted to touch on the very last point you made there, the reimbursement, because obviously regulatory clearance is great, fantastic, but it doesn't guarantee you can actually sell the product. So do you want to tell us a little bit about that reimbursement code?
Yeah, with pleasure. So it's a so-called temporary or Category 3 code that was approved by the Centers for Medicare and Medicaid, so our public insurance, now about 2 years ago. Usually reimbursement decisions are not made across the entire United States, but they are geographically separated according to regions. So icometrix and other companies have successfully lobbied for reimbursement, and especially over the last, I would say, 6 months, we are really starting to see appropriate reimbursement across the board. My billing has been very anxious about this as well, but the latest numbers are looking increasingly optimistic, and in fact, we are getting reimbursement on a regular basis.
Brilliant, well, fantastic. Another round of applause for Professor Anna Franceschi. Thank you.
Thank you so much.